Hello and welcome to another episode of the Life After Cardiac Arrest podcast with me, your host, Paul Swindell. And today I'm joined by Neil Magee, who is a cardiac specialist nurse at the Essex Cardiothoracic Centre in Essex. Hello Neil, and welcome to the podcast.
Hi Paul, thank you very much for inviting me.
My pleasure. Can you briefly tell me about your background and how you got into nursing?
Okay, so I've been nursing for 20 something years now. I didn't originally think that I would go into nursing, so I left school and was thinking of a career in the city, and quickly realised once I left university that probably wasn't what I actually enjoyed doing. And after working in a couple of insurance companies, definitely realised that it wasn't what I wanted to be doing. So I changed tack and went into work in a care home. That was partly inspired by my sister and a brother-in-law who are both nurses. I saw what they were doing and thought that's something worthwhile, and saw that they were fulfilled by their jobs and thought, yeah, I thought I could try that. So that's what I did. I worked in a residential home for people with disabilities and applied for my nurse training. And after a while, I found a university that would take me on, because at that time it was a little bit strange for somebody with all of their qualifications in business and finance to be applying for nursing. I did get some people to take my application seriously, and applied, qualified as a nurse in 1998. Worked in a general surgical ward initially, but always had a passion for cardiology throughout my training. The cardiology wards were always the wards that I had enjoyed working on most. And soon after that, I did my 6 months in surgery, which was then the kind of thing that you're expected to do when you qualified, and then went into a coronary care unit and spent just over a year there before transferring to intensive care.
Was that in Essex?
No, that was in Bath. I was living down there then.
So how did you end up at the Essex Cardiothoracic Centre in Basildon?
Yes, I grew up in Essex and moved back here in 2001. Worked in Southend Hospital in the intensive care unit there. When I saw the plans coming forward for a cardiothoracic centre right on my doorstep, I thought, fantastic. So I applied to work at the cardiothoracic centre as soon as that opened, and I was there for the opening week, and started in July 2007.
I was going to say, when was that? Yeah. Do you know what the motivation was for creating a cardiac specialist centre in Essex was?
The driver for it was that the government at the time had a pot of money for developing services. Cardiac services in the UK at that time were decades behind what other countries were doing. So in terms of management of patients having a heart attack, which myocardial infarction, so a blockage of one of the arteries. The gold standard is now that if you're getting certain ECG changes, then a stent is the right treatment for that. Whereas previously patients were going into their local A&E, they were given drugs to try and dissolve the clots, which are less effective than stents, and consequently more patients were developing heart failure symptoms after their heart attack because they were getting less effective treatment than they currently get. So the government had a plan to build more regional centres And in doing that, they would increase the capacity, the waiting times for a patient needing coronary artery bypasses or stent implants was significantly longer than it is now. So having centres like the CTC in Basildon and Essex and in most other regions throughout the county, they've also developed similar centres. So they've increased the capacity for being able to provide more modern medicine to patients with cardiac disease.
So how many patients in terms of cardiac arrest and heart attack do you see each year?
Cardiac arrest patients are around 130 to 150 per year at the moment. That has increased progressively since we opened. So if we go back 10 years, that number was probably between about 50 and 70. So it's almost doubled in that time. I think that's partly because of the reputation of the Cardiothoracic Centre means that the HEMS and air ambulance crews want to bring patients to the CTC rather than going to their local hospital, and also just the fact that the message is getting out there for early resuscitation and having more AEDs, the defibrillators in the community mean that more patients are surviving cardiac arrests, which is obviously a positive sign. So that's exactly what we want to see, that the chain of survival is working and more patients are surviving to arrive in hospital.
Absolutely, and you just touched on the chain of survival there. Could you sort of just expand on that a little bit? Tell us what that actually means and whereabouts the CTC fits into that.
So the Cardiothoracic Centre is a tertiary centre. So we are the kind of a regional centre for Essex and South Suffolk. So we're often a little way at the end. We're right at the end of the chain. The chain of survival begins with the person being recognised to be in cardiac arrest, somebody calling for help instantly, getting the paramedics there, and early defibrillation too. So if the patient is in a public place, say a sports centre, leisure centre, a shopping centre, anywhere where there's likely to be a lot of passing people, having access to an automated defibrillator that somebody passing, even if they don't know how to do, even if they haven't got the kind of formal qualifications in resuscitation, then they would be able to follow the simple instructions on the box, put the pads on the patient's chest, and the defibrillator will do the rest. So early defibrillation really is a lifesaver for these patients.
And you guys are on the receiving end for a lot of these, as we say, cardiac arrest patients. So can you sort of run us through what happens when a patient comes in? Okay.
So we've got quite a well-drilled team now. We've been doing it for quite a few years now. So we always get warning from the paramedic crews to say that they have been called to a patient that's had a cardiac arrest. They will give us as much warning as they can that they are about to arrive. That call goes through to the coordinator on the cardiology ward. They then inform the intensive care team and the cardiologists. So you have two teams of doctors and nurses that will be in attendance to be waiting at the ambulance bay door to receive that patient. We will then assess and treat the patient, normally going straight into the cardiac cath labs, which is where they do the angiogram, which is to look at the coronary arteries to determine whether the reason for the cardiac arrest is because of a blocked coronary artery or not. So you're looking to exclude that. If there's a blockage in one of the coronary arteries, they will be looking to insert stents in there to treat that blockage. Sometimes it's an electrical problem rather than a mechanical problem. Sometimes you need the electricians rather than the plumbers, to put it in more simplistic terms. The patient is then assessed and treated as they need to be. The anaesthetic team will be looking after the patient, putting them on the ventilator. In the Cardiothoracic Centre, we strongly believe that calling patients gives better neurological outcomes, and we've been involved in several studies in assessing that. The hard data out there is a little bit is mixed. So there is no firm evidence to show a positive correlation between outcome and whether the patient's called or not, but we believe that early intervention with calling does potentially improve neurological outcome.
I guess the key thing is to stop people overheating and getting a fever as such.
Yes, yeah. So we're currently involved in a study that is doing that. So it's comparing stopping fever with active cooling. So it's maintaining normothermia and preventing patients having a high temperature, which increases metabolic demands, compared to actively cooling the patient down to way below normal temperature and keeping them at that temperature for a period of time afterwards.
So how many people do you put, or do you put everyone into the cooling? Or I mean, if a patient comes in and they're still conscious, or they've been resuscitated, and then for whatever reason they haven't felt like they needed to sedate them at the scene, would you still call them if they came in conscious? Or
no? So it's only for patients that come in unconscious after a cardiac arrest. So if a patient is fully conscious and orientated and able to have a conversation with you, it's to prevent a brain injury that we would try and call the patient. If they're clearly fully compos-mentis and not having any difficulties at that point in time, then it's likely that the period of no flow or reduced flow of blood flow to the brain was limited, and they would have got early good resuscitation to keep the brain well oxygenated.
So what sort of percentage of arrest patients are in that state? That's
a good question. It's I would say it's probably about 75% are unconscious, and maybe 20 to 25% would be fully conscious and able to have a conversation with you.
And presumably they will go on to have a better recovery. Would that be the case?
Normally, yes. Yeah, it's a less complicated recovery, because patients that go into intensive care and need to be fully ventilated for a period of time, their neurological recovery is always uncertain. Whereas patients where you know from the outset that neurologically they're fully intact, then that's very reassuring from the outset. So it's very difficult when patients come in unconscious, because you just don't know how they're going to recover and how they're going to wake up, or in fact whether they're going to wake up. So unfortunately for some people, they don't ever make a good recovery. So.
Mm-hmm. So the patients come in either conscious or unconscious, and they've gone into the cath lab. And you said they quite often have an angiogram. Could you just tell me what an angiogram is?
An angiogram is where they put dye through the arteries and take X-rays of the coronary arteries to look for any blockages or narrowings that will require treatment with a percutaneous stent. So they will then, if they do see a narrowing which is caused or likely to have caused the cardiac arrest, they will insert a stent into that to try and sort out the reason for the patient having the cardiac arrest. Yeah.
So once any blockages have been cleared or no blockages found, you mentioned that there might be an electrical problem. Would that be dealt with there and then, or is it something that would be investigated there and then, or what would happen next?
Normally, the patient will be transferred to the intensive care unit, and they will then try and stabilise the patient. If there is an electrical problem, sometimes it does need immediate treatment, and if it did, they would put a pacemaker in, or some kind of pacing-like device immediately. But normally, if it is an electrical problem, they normally wait until the patient's stabilised before putting one of these devices in, because the risk of infection in the acute phase is much higher. Most patients, when they have a cardiac arrest, they lose control of their airway and they aspirate stomach contents down onto their lungs. So normally they do require a period of treatment with antibiotics to prevent any lung infections which may interfere with their devices and pacemakers or defibrillators that may or may not need to be implanted afterwards.
Do you see many patients that have additional injuries because of how they've gone into arrest, maybe through driving or I don't know, if they're on a roof or something like that?
Absolutely, because of the nature of cardiac arrest being unpredictable, then what the patient was doing at the time of their injury can cause consequential problems. So like you say, if the patient was driving, they may have crashed the car and have rib fractures because of the steering wheel and internal trauma because of any impacts because of that. So the management of patients post cardiac arrest needs a much more multidisciplinary approach than your standard patient that's having a heart attack. So the reason for the cardiac arrest may have been because they had sepsis or something else going on at the time. So there may have been other systemic inflammatory processes going on that may have tipped that patient over the edge to have a cardiac arrest. So.
Mm-hmm. Yeah, I guess they make a lot more complicated and interesting, maybe, patient to look after.
Yes. Yeah, it's certainly more challenging when
yes, that's the word, challenge.
when you're trying to stabilise a patient that's had a cardiac arrest, it is a huge insult on the body, and the consequential organ dysfunction as a result of that does cause other difficulties for both the patient and the medical team looking after them. Yeah.
So from there, I presume you mentioned they went into the ITU. Yeah. So how long are typically patients in that for, and what's happening in that area?
Length of stay in critical care varies enormously between patients. For some patients, it can be as short as 24 or 48 hours. In other patients, it can be weeks and months. So it depends very much on how much damage has been done, both in terms of the impacts on the heart and other organs. So primarily the three main organs that are affected in the first couple of days are the brain, the heart, and the lungs. Consequently, after 24, 48 hours, you often see a knock-on effect on the kidneys and liver. So if they develop multi-organ failure, then they are the patients that then have a very protracted and longer journey to recovery and to getting out of critical care.
One of the things that I see from people I saw a lot just recently is issues around intubation. Can you sort of just talk about what that is and why that might give people a problem?
Yeah. So intubation is when a patient needs assistance with their breathing. So that's either because they're unconscious and not able to breathe for themselves, or they're kept on a ventilator because the work of breathing is too much for that patient because of other things that are going on with them. So sometimes patients are kept in a medically induced coma and they need to be intubated for that reason to try and stabilise them and so that the underlying cause of their problem can be dealt with. So intubating a patient is when the tube is put down the patient's windpipe to allow a mechanical ventilator to take over the work of the breathing. So the intubation is putting a tube down through the mouth and into the windpipe.
I do see some people saying that they have sore throats. I remember I had a sore throat for quite a while afterwards. It's just one of the byproducts.
It is, unfortunately. The tube is held in place by an inflatable cuff. That's inflated in the trachea, and the area around there can get quite inflamed. Depends, one, how long it's been in there. Everyone's anatomy is slightly different, and some people react to a tube being there more than others. But it does normally. It depends primarily on how long it's been there. So if it's been there 24 to 48 hours, it's a relatively short period of time. If it's been there up to a couple of weeks, then you're more likely to get more significant sore throat and things like that. And for patients that aren't able to wake up within that 7 to 10 day kind of window, that's often the time frame that we think about putting a more secure airway in. So some patients will have a tracheostomy performed in that kind of 7 to 10 day window if we haven't been able to get them off of the ventilator to help with the breathing.
So what's the process of getting them off of the breathing and waking them up? How do you go about doing that, and at what time do you start that?
It depends on how cardiovascularly stable the patient is. So we're in intensive care, we're constantly monitoring blood gases, which are looking at the acidity and oxygen levels in the blood, and the carbon dioxide waste products and things like that. So we're assessing using that and the other kind of invasive monitoring that we're doing in terms of blood pressure and neurological status and things like that. Once we're happy that the patient is stable and is able to progress and increase the work of breathing, we will turn down the sedation first, and then gradually we will continue assessing the patient. If they're starting to wake up and to initiate the breaths on their own, we will taper down the amount of help that the ventilator is giving the patient to the point where eventually the sedation is turned off completely, the patient's able to breathe for themselves, and at that point we can take them off of the mechanical ventilation, take the tubes out, and then just give them face mask oxygen to breathe for a period of time if that's necessary.
Would the cooling be turned off at that point as well?
Yes. Normally we wouldn't try and wake somebody up until they've come back to normal temperature, because it's very uncomfortable to be kept cool if you're fully awake. So shivering would increase the metabolic demands on the body. So it's more comfortable for the patient if they're completely sedated until they've been warmed back up to a normal temperature.
So the temperature would be one of the first things, I guess. And
yes.
At what period when do you start doing that, do you know?
Normally 24 hours after they've reached target temperature. So we cool patients down as quickly as possible. Some patients are down to target temperature in a matter of minutes. In others, it can take a few hours. It depends on what temperature you're starting at. So if they've already got a fever, when you start, they've got a bit further to go to get down to the target temperature of normally 32 to 34 degrees. It's normally after 24 hours of keeping them at that regulated temperature that we would start to increase it very gradually by about half a degree an hour. And so it from the time that you start rewarming, it's often 6 to 8 hours after that you get the patient back to a normal temperature that you can think about turning the sedation down and waking them up. We are using different medications to prevent shivering now. So in some patients we are starting to wake them up whilst they're still being cooled, and we have had good successes with that. But it's not always standard practice to wake somebody up whilst they're still being cooled. Mm-hmm. But it can be done.
So what happens if you warm someone back up again and then you remove or lower the sedation? Presumably you want them to wake up at that point, and so what happens if they don't wake up? If
they don't wake up, you continue with supportive therapies in terms of the maintaining the breathing with the ventilator and maintaining blood pressure with any medications that may be necessary for that. Some patients take a lot longer to wake up than others, so it's very variable, and for some patients it means that they need weeks in the intensive care unit, and for some it can be months even. So it's sometimes a very long journey for both patients and their relatives.
So what's the sort of longest that you've ever known anyone to actually be sedated and then make a good recovery?
The longer somebody needs to be sedated for, and the longer it takes them to wake up after a cardiac arrest, is quite often a negative prognostic sign. So the fact that somebody doesn't wake up quickly is often an indication that there has been more neurological damage that has occurred during the cardiac arrest. So it doesn't always. It's sometimes very difficult to correlate the length of time that a patient's had as of requiring full intensive care support and their recovery. So I'm afraid I don't know if I'm going to be able to give you
that's not a problem.
Clear.
I don't want to put you on the spot at all, but it's just I ran a survey in the group yesterday about how long you were in a coma, because there was a couple of questions about that, posts related to it, and I was quite surprised how long some people have been in a coma. That I always thought it was just that mostly it would be a couple of days at most, but there are many that are weeks.
And that's not unusual. Sometimes it's longer because of lung problems. If it's longer because of lung problems, then that's more often reversible and treatable, and they can still make a good neurological recovery. If the reason that they are needing the ventilation for longer is because the body's not triggering to tell yourself to breathe, then that tends to indicate that there has been more significant brain injury, and there are the patients that tend to spend a lot longer in intensive care and sometimes don't make such good outcomes.
So, assuming that what's someone like when you actually bring them back and they do wake up? How are they basically?
Normally very agitated. Most patients have got no idea where they are. They wake up and they've got tubes going in and out of their body for monitoring. So they've got the tube for the breathing is still down their throats. They've got wires going into their veins in their arms, in their neck often, and into the artery as well to constantly measure the blood pressure. So they've got lots of tubes and wires and ECG monitors and things. So they're hooked up to a lot of equipment, and it can be very distressing for some patients. So some will become very restless, very agitated, and can be quite aggressive. Other patients will just be very emotional and just find it very distressing. And most patients will find that their short-term memory is very impaired, and they will be constantly asking their family the same questions over and over again. That's very common, and these patients needs lots of reassurance, and the nursing and medical staff will be constantly reiterating why they're there, what's happened, and trying to explain what the different tubes and wires are for to try and orientate the patient back to where they are and why they're there. Because for most patients that have had a cardiac arrest, they miss large chunks of what happened immediately before their cardiac arrest, and sometimes days and weeks beforehand. So it depends on the individual, but the memory is often impaired initially.
In the you mentioned about the memory being impaired there. I've been told that I ask the same questions over and again, and I've heard lots of other people say that as well. Is that because of the damage to the memory, or is it a medication, or is it a combination of both?
Yeah, you're right. It's a combination of both. So some of the medications that we use to medically induce the coma does have an effect of amnesia. So it can be a medication effect that is exacerbating that, but it's also the fact that when the heart stops, the oxygen flow to the brain also stops. Any period of time where there's no oxygen flow to the brain, you do get cell damage and cell death. So short-term memory is particularly vulnerable to that. So in the early days, particularly after a cardiac arrest, patients do find that the brain is very inflamed and very irritable, and they do find that short-term memory is often quite significantly affected.
While this is all happening with the patient, obviously one of the other main players in these scenarios are the partners and the families. So, and they've probably gone through a horrendous trauma, and quite often they would have witnessed the event, or even had a part in resuscitating the patient. How do you deal with the patient, the partner and the family, and when they see their partner waking up?
That can be a very traumatic time for patients next of kin too. So trying to support the family through that journey is very difficult, and a big part of what we do in intensive care is often looking after the relative as well as the patient. So particularly if they have been involved in the resuscitation themselves, if they were the first person on the scene, if they had called the paramedics, if they had started the CPR, that's a big burden to be carrying. And when they see the patient waking up and the patient's very agitated, very restless, it can be very traumatic for the family, and the And the whole time that the patient's in a coma is an extremely stressful time for the families, and there's nothing that you can do to prepare or to comfort somebody until the patient wakes up and they're talking to you normally. We can't offer any real concrete hope other than that everything is being done that can be done, and
the tools are giving you the information that they can, and I guess the tools aren't totally black and white. You're never going to know whether it's going to be a good outcome or a bad outcome. I guess from you guys, you've probably got quite a lot of experience, and you get a bit of a gut feel whether someone's going to make it or not.
Yeah.
But you probably, you can't let on too early, or I don't know.
No, it's very unpredictable, and there are some patients that on paper you would look at the stats and look at the information that you're given from the paramedics and may think they've got a low chance of making a good recovery. And we've had lots of patients that on paper you may have written off, but have made fantastic recoveries. And conversely, we have some patients that have very short downtimes, but have very poor outcomes, and it's very difficult to predict in the early stages, at least, which patients are going to make a good outcome and which ones aren't. The testing and information that we're able to do with EEGs and other forms of monitoring are getting slightly more sensitive and able to pick up markers that give better indications, but it's not completely black and white. There's a lot of grey in that, and sometimes it is just a question of time and giving the patient time to make that recovery.
So is age a factor in this? Would you say that younger people do better than older people, or is there nothing in that?
In some respects, yes. I think age is always a factor that does come into play. Unfortunately, patients that have a cardiac arrest at a younger age sometimes have quite significant comorbidities that go with it. It's not always the case, but sometimes if you're having a cardiac arrest at a very young age, sometimes that's not always a good sign that's happened to you. And consequently, you get 90-something-year-olds that make fantastic recoveries, and you may not have expected that. So it is very unpredictable, and age is quite an unreliable, I think, indicator of whether or not somebody will make a good recovery. In terms of being able to recover from an insult and multi-organ distress, younger patients tend to have a bit more reserve and a bit more resilient than an older patient. But sometimes the older ones are made of tough stuff, and they are very resilient.
So when the patient's woken up and they've been in, I guess they get moved to a normal cardiac ward, but then how long is it before they get discharged, and what are the sort of pointers that you get, and then what happens once they get discharged? And I believe one of your other hats is the care clinic coordinator.
Yes.
So there's quite a lot of information or questions in that one statement. So.
Yeah. Okay. So I'll break that down a little bit. So initially, once a patient is what we would say cardiovascularly stable, so their heart and lungs are working without any additional support, and they're neurologically able to be able to support that, then we will look to transfer the patient down to Roding ward, which is our cardiology ward. They have a high dependency area there, which is where the patients will go initially. And as the patient improves, they will then transfer down to the normal part of the ward, and the process working towards discharge is put into place. So there's a bigger team involved in the discharge process. So obviously the cardiologists are responsible for the patients, so it's their decision. But the nursing team have a big input into that. You've also got the physiotherapists and the occupational therapists that have a key role in assessing and monitoring any other needs of the patient. So it's about making sure that not just the patient's fit from a cardiac point of view, but it's also looking at social factors, any other things that have happened during the hospital stay, which means that their ability to live independently when they go home has altered. Lots of patients do need more support once they go home than they did when they came into hospital. So it's about making sure that the right package of care is available for the patient before they're discharged.
I sort of touched on about the fact that you're the care clinic coordinator, and I was in your hospital 2014.
Yep.
And from what I understand from Dr. Keeble, that was just about the time you were starting this project. Could you sort of give us a little bit of background and what's happened with it, and tell us about it, basically?
Yep. So just before then was when we had done one of our first calling trials, and we did a smallish study looking at two different types of calling device and assessing patients as to which was more efficient in calling the patient down, and whether that made any difference to outcome. We had always kind of suspected that this group of patients would have more complex needs on discharge, but we'd never looked at it. So Dr. Keeble and myself asked some patients to come back, and it was just a handful of patients that we'd chosen from the patients that had been in the calling trial. In terms of outcome to survival, we reported fantastic results. 67% survival, which was way out there in terms of all comers cardiac arrest, in terms of outright survival. So we were quite pleased with ourselves, I think, in terms of how well the patients had done from a purely medical point of view, looking at the numbers of survivors and how well they were functioning from a neurological point of view at the time of discharge. So they were going home and they weren't all dependent and needing a lot of assistance. However, what we found when we brought patients back was that either the patients or their family member were finding we were effectively seeing significant post-traumatic stress symptoms, lots of anxiety, lots of depression, and difficulty adjusting to life after the cardiac arrest. We were a little taken aback by that and thought, okay, these patients are making a great medical recovery, but the whole kind of package, we're not getting that at all, and something else needs to be done. So we had a look around the UK to see what other centres were doing, and other centres were doing exactly what we were, absolutely nothing. So we said, okay, this isn't good enough. So we looked a little bit further afield, and Dr. Keeble found some research by Dr. Mullert, who works in the Netherlands, and she had published a couple of very nice studies on early intervention with post-cardiac arrest survivors to look at what they were doing over there. Rehabilitation in the Netherlands is a medical speciality in itself, and Dr. Muller works in a centre that's probably about the size of Basildon Hospital, that's purely for rehabilitation.
So from any medical
yes,
problem.
Yeah. Rehabilitation is given a lot more kind of weight in some other countries than it is in the UK. So we were lucky enough to. She was over here at a conference, and she was kind enough to give us some of her time to describe how she set up her clinic, and which is run by 2 nurses, and she told us what kind of testing they did, what kind of interventions that they were providing, and we sought to replicate that. So as a way of doing it under the radar slightly, we set up our own research trial, which was 20 patients in each arm, and that was back in 2014. So you were actually one of the early patients that were into that trial, but unfortunately you were the one of the patients that were being looked at retrospectively. So the first 20 patients that we saw, we invited them back after the event, and we saw them between about 3 and 9 months after their cardiac arrest, and we just brought patients back, asked them how life was with them, and I don't know if you remember, we did some testing that looked at concentration, memory, and some general quality of life markers there. What we found was that at the baseline, patients were in a really bad way, and when we compared it to patients that have other chronic life-limiting diseases, like chronic liver failure, chronic renal failure, significant respiratory diseases, severe depression, and other things, the cardiac arrest survivors were pretty much down at the lower levels in most of the quality of life outcomes at that point. We then took another group of 20 patients who we entered them into the trial whilst they were still inpatients. We gave them a little bit more support before discharge home. They were given information leaflets. They were given a contact number to call. So they were given a slightly better package of care, if you like, to go home with, and were seen in clinic at 3 months and at 9 months afterwards. Sorry, was it? No, 3 and 6 months afterwards, and assessed at that point. We also had a consultant psychiatrist that was reviewing the patients in clinic if they required it. So we had a slightly more holistic. We weren't just looking at the cardiology and whether the stents were working or whether the pacemaker was working, and which is normally all cardiologists are interested in their standard follow-up clinics. So we were looking at the psychological needs and of patients afterwards, and that was the main focus for the clinic and setting it up, was to be looking at the kind of psychosocial needs of the patient, and we found that patients that got more support, unsurprisingly, had better outcomes.
In terms of what?
In terms of being able to return to work earlier, and in terms of quality of life. The quality of life kind of questionnaire, patients were scoring higher on that if they'd had a bit more input in the early stages after discharge.
How about the partners as well?
We also assessed the partners, and they too. It was interesting that the partners had similar kind of stress and anxiety levels to the patient. So whilst the patient had been through the traumatic experience, the the relatives were also showing signs of post-traumatic stress and anxiety disorders as a result of supporting their loved one through the cardiac arrest.
So did these patients go on to receive any, and partners receive any counselling or?
Yes, yeah. So some patients were referred for counselling. Some patients were seen by the psychiatrist over a period of time, and so where necessary, they were referred to appropriate services to be treated. That was the kind of starting place. Since then, we've tried to maintain that as a baseline standard of care. So I would try and see all patients whilst they're still an inpatient before discharge home, give them the information leaflets. We've also got Dr. Marco Mion, who's a neuropsychologist, who's come on board recently. He's been doing some work with our patients, so he does the early part of the follow-up now. So he sees patients either as an inpatient or soon after discharge, and he normally sees them about 3 months after that too. He will then hand the patients back to myself, and I normally see the patients about 6 months after discharge. So the early interventions, if they're required, are done by Marco Mion, and then afterwards I take over, well, not take over, but patients are referred on to me, and I just make sure that the ongoing needs of the patient are being met. And sometimes I think the most important thing that I do in clinic is listen to patients. So for some of them, it is information that they want. For others, it's an opportunity to express all of the things that have been troubling them over the past few months.
So you're becoming a kind of counsellor in your own way, are you?
Yeah, I guess so. I have to put my hands up now and say I've got no formal counselling experience or training, but I like to think I've got an empathetic ear. I think that's the most important thing that I do offer to patients.
Yeah, I totally agree with you in that. I've heard a lot of people who say that talking about it helps enormously, but it has for me as well. It's partly why I'm doing this, I guess.
Yeah.
But yes, it certainly does. It's good to talk, as it used to say.
Absolutely, yeah.
It was at BT.
Yeah.
They weren't wrong, I guess.
No.
So where's that was 2014. Have you published results from that at all? What you were doing there?
So it's finally got to publication, and it is. I got the draft a couple of weeks back, so I don't know if it's out there and fully published, but yes, it is in. I think it's the Journal of Neuropsychology, but I'll confirm that one with you. But yes, it is finally getting into print, and it does show that in the results showed, as I suggested earlier, that in the early 3 to 6 month period, patients that don't have any or don't feel that they have any support in that period of time take longer to adjust to life after cardiac arrest than those that are given relatively simple interventions of being seen in clinic, possibly just normalising what they're experiencing, what they're going through, and having the opportunity to discuss it, being referred to other services like counselling, like neuropsychology or psychiatrist if necessary, memory clinics and all of those other things that we know are important in getting somebody back to the best health that they can.
You touch on memory clinics there, and I know that one of the big common problems, is short-term memory issues with members of the group and myself as well to a certain degree, although I think that's improved a bit. Can you tell me any more about that? Is that a common thing? And is there? You mentioned memory clinic. I wasn't aware there was such a thing. Is that something that people get referred to a lot now?
Yes. Yeah. So memory clinics are something that have tended to be used in relation to dementia and Alzheimer's for many years. But we're finding that many of the patients that are coming through our services also have problems with short-term memory as a result of what we call hypoxic brain injury. So they also have difficulties with short-term memory. It's a different mechanism to the patients that have dementia or long-term kind of degenerative illnesses, but it's the same effect. So GPs are quite happy to refer patients into the memory services clinics and for patients to be assessed there and any treatments or suggestions for that are dealt with by the specialists that specialise in those areas.
So are you finding you're referring to all sorts of other specialists as well?
Absolutely, yeah. So physiotherapists, sometimes speech therapists and occupational therapists, and memory services are the common ones that we refer to. Counselling is also something that is often very important, and like you said, it's good to talk and having somebody that is just completely detached from the situation. So it's good to talk to family members, and family members are absolutely crucial in often getting people back to a good recovery. But sometimes it's too close to home to talk to a close family member or to a partner, or
especially if they were there and they've gone through that trauma, and trying to talk to them about it only resurfaces that trauma.
Yeah, definitely. And sometimes it's not only the patient that needs the counselling, it's quite often the partner of the patient that also needs the counselling in their own session. So it often doesn't work if it's a joint session, and it works much better if you do split the patient and the relative up, and you give them both the individual attention. So that would be the gold standard, would be able to provide that, to take the patient and the relative into different clinic rooms and talk to them about their individual issues like that.
Just going to come back to that, but one thing you mentioned, you said about a leaflet. I believe you also, one of the reasons that I've sort of I remember coming to the CTC and doing the survey and some tests and that. But the reason I came into contact with Dr. Keeble was because I saw your face in the video in the similarly named Life After Cardiac Arrest.
Yes, there's a theme there.
You haven't got copyright on that.
No. I think Tom might, I'm not sure.
Could you tell me, and also you mentioned a leaflet, could you tell me a little bit more about that video and the leaflet?
We recognised that there was a huge unmet need at that time, and we wanted to find a way of being able to get the message out there to as many potential patients and relatives as possible. And we realised that what we were trying to set up in Essex in the Cardiothoracic Centre wasn't happening in other cardiac centres. So we wanted just to show something that went slightly beyond the borders of Essex. So putting a video onto YouTube was a good way of being able to reach a wider audience and to really put the message out there that recovery from cardiac arrest is much more than just looking after the heart and the stents and or the heart and the pacemaker or defibrillator.
It's more than just cardiology.
It's much more than cardiology, and just trying to raise awareness really as as much as anything, and to try and get other centres interested in trying to provide a similar level of service that we're trying to set up. And I think we also use that as a way of trying to establish funding for what we were trying to do, because when we set it up as a trial, and basically we didn't stop because we saw that there was such an unmet clinical need, whilst the commissioners and things like that still haven't probably fully recognised the need for it, and the funding streams definitely aren't quite in place. So the Cardiothoracic Centre has been very good in allowing staff to provide the service without really being reimbursed for it in terms of the normal funding streams that you would expect to be provided by the commissioners. I think that's one of the reasons that other centres haven't probably jumped on board quite so readily, because they probably won't get paid for it.
I mean, you're very, very well. We're all very, very lucky that we've got a sort of related local charity, which should give a shout out to.
Oh, definitely, yes. So SADS UK have been very generous in their funding. So Dr. Meon's research has been funded by them to allow the neuropsychologist and neuropsychology support to have continued for the last 2 years. So lots of charity support has allowed us to get to where we are today. Thanks very much to them.
Indeed. So did you say, well, has there been much traction with the video? I know you've had almost 40,000 views on it on YouTube, which is quite impressive, or very impressive. But is it hitting home with the other centres across the UK?
It's starting to. So Dr. Keeble was involved in a conference in Edinburgh, which I believe you also attended, and there was a lot of interest generated from that, and I have had nurses and OTs from other centres recently come and visit the clinic and wanting to emulate it and set it up in their local hospitals too. So there is more interest coming in, and slowly it's kind of drip feeding around, and the message is getting out there wider. So Barts, which is probably the UK's biggest cardiac centre, they have come on board and are interested in setting up, and I think they have now established a similar kind of setup to us. So the message is getting out there, and it is getting a wider spread. So there are things in the pipeline that are making it more likely that services are going to be better provided for nationally, rather than being a bit of a geographical lottery at the moment.
I guess it's going to be a while before we ever see this as part of an NHS care pathway, though.
That's what we're trying to establish. So Dr. Keeble is fundamental at the moment in driving that. He's on the board of the Cardiovascular Society, and he has tried to steer the committees that commission cardiac arrest centres. So they're trying to establish some cardiac centres as being specialist cardiac arrest centres in a similar way to some centres specialist aortic dissection centres and things like that. So specialist services being offered in certain centres. So to be accredited as one of these specialist centres, Dr. Keeble is trying to ensure that unless they've got proper follow-up care afterwards, that then they can't be it's not about being restrictive, because we want to encourage as many places to be providing that care as possible. So it is going to be about trying to be inclusive and getting people on board and getting people to recognise what's often an unmet need.
Indeed. And I guess if you can roll it out across the country, will actually ultimately save the country probably money
in the long term. Probably yes, yeah. Because
from what you said, people go back to work sooner and they've got a better quality of life, so they'll be able to engage more in life. Do you find that you did sort of mention it earlier, that about adjusting to life, and in your video the psychiatrist mentions about adjustment disorder.
Yeah.
Could you sort of explain what that is and tell me your view on it?
So in terms of the health economics, if you like, of Dr. Mullert in the Netherlands, that was one of the questions she looked at in her research, and she did find that it was a net save in terms of the ongoing costs in terms of health care and social care for patients that receive the early intervention. So whilst the upfront costs are slightly higher for providing those services, the net gain was offset by the reduction in GP visits, in other associated healthcare costs further on down the line. So she did show that it was beneficial in terms of saving the health service money in the Netherlands, which I'm sure would be transferable to here, but we haven't got any studies that back that up in the UK, but I'm sure that would be the case. The second part of your question was about
adjustment disorder.
That's right, sorry. With regard to adjustment disorder, that is essentially a patient's life before they have a cardiac arrest is almost inevitably going to be very different to their life after the cardiac arrest. So it's about how the patient copes with that transition and is able to adjust to it. So the psychiatrist did use that term, adjustment disorder, because patients' lives are often very different after a cardiac arrest. So there may be some things that have got a lot worse. So one of the most frequent examples of that is initially short-term memory. For some patients, they make amazing recoveries, and it is a catalyst for them to make lots of significant life changes, and they say that it's the best thing that's ever happened to them, and they've straightened their lives out and sorted all sorts of things out. So for some people it can be a positive thing, but their life is almost always different after a cardiac arrest to how it was beforehand. So it can be very, very difficult for people to adjust to that, and because of fatigue and short-term memory difficulties, sometimes it can be hard to go back to work, and if that person was the main breadwinner for the family, it then puts different pressures on other members of the family to also adapt to their changing circumstances. So it's very difficult for not just for the patient in terms of the adaptation, it's also for the patient's families too.
Indeed. So is there any sort of there's PTSD, which is a disorder as well, and there are various treatments for that. So is there a treatment, as in quotes, for adjustment disorder, or is it just something, I don't know? Is there a treatment?
There's no kind of set prescribed treatment for it, but counselling is often the thing that we do, not necessarily prescribe, but recommend to patients and refer them to a counsellor to try and look at how they can adjust and adapt and change their mindset sometimes to
the new life, the new you.
Yeah, absolutely.
Well, it's not just the new you, is it? Because, as you said, the partner will sometimes have to adapt and change to the new circumstances.
Yeah, quite.
Well, Neil, I've taken up over an hour of your time, and it's been a fascinating journey through life at the CTC and the care clinic, which is cardiac arrest resuscitation, I believe, as it was, but it's going to be changing, isn't it?
Yeah, it was the initials. Care were Care After REsuscitaion, so that's how it started out. So that was the kind of inception of it. But I think Dr. Keeble's got ideas to.
It's actually a sensible and nice acronym. Isn't
it is. Yeah.
One of these convoluted ones that you come across.
No, it was quite straightforward. We wanted to put it out there as. Something simple, something that patients can recognise, something that other health professionals can recognise as something simple and does what it says on the tin effectively. That it does look to provide care to patients post resuscitation that need it. So.
Okay, and just to finish on, can I ask you, have you got any tips for patients or family members that have just gone through a cardiac arrest, and have you got anything to sort of ease any anxieties or just to help them along their way?
I think in terms of general advice, it's take one day at a time. So don't be trying to rush too far into planning for the future. Take each day as it comes, because things do evolve in different time frames. Try to get as much help from as many sources as possible. So knock on all of the doors that are available to you. So if you have been given numbers and people that may be offering and providing help, use them. Fatigue is a big problem after a cardiac arrest for the patient, and also for the caregiver too. They can become very fatigued because the whole process of what you're going through is absolutely exhausting, but both for the patient and the relative too, because the number of nights of disturbed and broken sleep that you get both as a patient in hospital and as a caregiver, when you're at home worrying about the patient that's in hospital.
So a lot of people I see get or hear of go into sort of an overprotective mode, as if they've got a brand new baby in the house.
Absolutely. So trying to wrap the person in cotton wool is a perfectly natural reaction. The patient sometimes feels very claustrophobic and stifled by that. That's part of the adaptation. So it is about being understanding to what the other person's been through as well. So whilst they may have been the one that was in the coma and had all the tubes, wires and everything else stuck into them, and it's their body that is recovering from whatever they've been through, the person that's with them has been witnessing some pretty awful things, with the uncertainty of not knowing if they would come out of it at all. So that's a very difficult journey to go through as a relative too. So it's about having the insight and understanding to think of what your partner or what your children or what your parents have been through, to try and just look after one another, and the key to a good recovery is often using family support and making the most of that. Try not to do too much at once. So having goals is a good thing. So having targets to work towards, but be kind to yourself and make sure that you factor adequate rest and recovery in. If you've had a busy day one day, you're probably going to feel wiped out for 2 or 3 days after that. So it's about not trying to load your diary up with too many things and expecting to be able to do all of the things that you're previously able to do. It is about trying to just break things down into more manageable chunks and as I said, take one day at a time and go from there.
That's absolutely fantastic, Neil. I'm sure lots of people will take some heart in what you've just said and will hopefully go forward in a better way. Okay, thank you very much for coming and talking to me tonight about this. And,
my pleasure. Thank you very much.
Hopefully we can meet up again soon.
Yeah, definitely.
Thanks a lot.